Judging by the number of new Class II correction devices being introduced these days, one would be safe in assuming that Class II treatment is certainly one of the most talked about topics in orthodontics today. While I don't think many would argue the effectiveness and the results that can be achieved with traditional headgear, the challenge is achieving those results with patients who choose not to cooperate fully during their orthodontic treatment. Within the past few years, great steps have been made towards making the Herbst a more comfortable and reliable appliance. The Mora appliance offered by AOA has also found its place in the orthodontic community by providing a fixed appliance that provides results similar to that of a twin block. The major drawbacks to some of these appliances, though, is the setup time, the lab time, and potentially the cost. Ormco's newest non-compliance Class II device, the Bite Fixer, may be just the answer if doctors have been hesitant to try the Herbst, the Mora, or other devices such as these. I'd like to spend a few minutes today describing the product, some applications for it, and lastly a few tips for using the Bite Fixer as effectively as possible. Many different spring-type devices have been introduced to the orthodontic market recently. However, most have been fairly unreliable and prone to breakage. We've designed the Bite Fixer with several key elements in mind. First, and probably most importantly, the spring was designed with the ability to stretch, which helps eliminate breakage when patients open wide and yawn. Secondly, the spring is crimped to the end fitting to prevent the possibility of the two separating. Lastly, the lower end fitting of the spring is crimpable. We realize that some patients can and will break the springs. The crimpable attachment makes replacing the spring much easier than the other appliances. The Bite Fixer is a spring module that exerts its force in a similar manner to that of a high-pull headgear. The spring delivers a force that is distal and intrusive, which is why so many clinicians have turned to the Bite Fixer for brachyfacial Class II cases. The Bite Fixer can be an effective tool for correction of Class II asymmetries. By leaving one side passive, or maybe not installing the spring at all, the side with the active spring will correct the malocclusion as well as the midline discrepancy. Let's take a look at a patient that was treated during our clinical trials. The patient is a 12-year-old female who presented with a severe skeletal Class II with retrognathic mandible. The doctor's recommendation was for surgery, but the patient and the parents declined. The doctor chose to give the Bite Fixer a try. After approximately 6 months of leveling and aligning, the Bite Fixer springs were placed. Springs were placed in a passive manner to allow the patient sufficient time to adjust to them. This slide shows the springs being reactivated after 2 months. After 10 months activation, you can see the correction that has taken place. Both the molar relationship and the cuspid relationship have been improved dramatically. The distal and intrusive forces that I mentioned earlier are also seen here in the posterior region where an open bite has developed. This, however, is easily corrected with finishing elastics. Final detailing in this case was approximately 6 months. Another fairly typical case presented to orthodontists is the Class II Div 2 dental malocclusion with a Class I skeletal relationship. Total treatment time was 19 months for this 13-year-old male patient with minimal requests for cooperation on his part. As discussed before, treating asymmetries or midline discrepancies can also be achieved with the Bite Fixer. The slides you are seeing now show the spring placed on the patient's right side only. 9 months later, the spring is removed and finishing elastics placed to close the posterior open bite. Another point I'd like to make about the Bite Fixer is an alternative to the standard placement of the Bite Fixer springs. This slide shows, as some of the previous slides have shown, that the Bite Fixer can be attached to an auxiliary wire. This is a close-up shot of the auxiliary wire installed in the double tube of the lower first molar. By placing the Bite Fixer springs on the auxiliary wire, range of motion is extended. This allows the patient to open completely and minimizing breakage. Another point that I made earlier in the presentation is that many doctors have found it advantageous to leave the springs in a passive position for the first activation. This allows the patient to grow accustomed to having the spring placed intraorally. Because of the distal and intrusive forces delivered by the Bite Fixer, a posterior open bite is a common occurrence in Bite Fixer treatment. This is very easily taken care of with finishing elastics and detailing the final occlusion. Lastly, I'd like to thank Dr. Jim Aubrey of Alpharetta, Georgia, for providing us not only clinical feedback during the trials, but also providing the photographs of the patients treated during those clinical trials for use in this presentation today.